All right, ladies and gentlemen, I think I have finally figured this thing out, and so I am now recording for the 5th time your Week 5 PowerPoint on ventricular arrhythmias. But this time we've got it. All right, so ventricular arrhythmias, we've been talking about supraventricular rhythms all this time, and that means we've been having these rhythms that begin above the ventricles. And because of that, they hit the AV node and they're able to travel completely down through the His-Purkinje system and all those nice electrical conductive fibers where everything is efficient and simultaneous, and we have a nice narrow QRS complex. But these ventricular rhythms are going to be different. So rhythms that begin in the ventricles are going to have a wide QRS complex. That is a duration that is greater than 0.12 seconds, or 3 small blocks. Now, not all rhythms that have a wide QRS complex originate in the ventricles, but essentially all ventricular arrhythmias will have a wide QRS complex. As I mentioned before, sometimes you can have abnormal or aberrant conduction through the His-Purkinje system, and we call that a bundle branch block. We'll get into those after the midterm. But right now, the only wide QRS complex rhythm that you have really talked about is Wolff-Parkinson-White. So where we get that short PR interval, the delta wave, and the wide QRS. Now we're adding the ventricular arrhythmias to that differential diagnosis. So why does a ventricular rhythm have a wide QRS complex? Well, I'm so glad that you asked. Because rhythms that begin above the ventricles come down normally through the atria and hit the AV node. It then will travel again down the efficient wiring of the His-Purkinje system and down simultaneously through the intraventricular septum and into the right and left ventricles, where they can contract at the exact same time. But with these ventricular arrhythmias, we get an ectopic focus somewhere in the right, left ventricle or intraventricular septum, and it's not coming from those efficient electrical conduction fibers. Therefore, everything is slower, and it starts on one side and has to go all the way across the other side of the heart. Duration of the QRS complex is telling us the duration it takes for depolarization to occur. And so because it's inefficient and it's also traveling from the one side or the other, instead of usually in the intraventricular septum, we end up with a wide QRS complex. The most common of the ventricular arrhythmias is what's called a premature ventricular complex. Some people call them a premature ventricular contraction. I'd like to call them PVCs for short. It's a super common arrhythmia. It's something that you will see in healthy individuals and those who are sick. And it is usually a daily part of our practice. In the emergency room, when we have patients on telemetry, we will almost always see some PVCs occur. Now, this is a single ectopic focus somewhere within the ventricles that is firing prematurely because of some irritability in the myocardium. Now, that can be things such as myocardial ischemia or infarction, or in healthy individuals, maybe just a little bit of stress over your pharmacology exam. So it's a single ectopic focus somewhere within the ventricles that is contracting. It's taking longer to go all the way across through the myocardium rather than through the conductive tissue. So we get this wide, bizarre appearing complex that we have right here. Now, so if we check the regularity of the rhythm here, we have a nice regular R to R interval. We would expect that next QRS complex to land right there, and yet it doesn't. We end up getting a premature complex right here. Do you need? So not only do we have these premature beats, one of the things that we sometimes can see with a PVC is retrograde depolarization of the atria. Now, this is not common. Most of the time we have what's called AV dissociation, where the atria and the ventricles are not communicating with each other. But on occasion, you can get retrograde depolarization of the atria, and you can spot an inverted P wave somewhere within that QRS complex or nearby. But oftentimes, even when it does retrograde depolarize, that's going to be hidden within the QRS complex and not seen. So, so these beats are premature from an ectopic focus in the ventricles. They can retrograde depolarize the atria, but when they do, it's hard to spot it. Again, this can be seen in healthy individuals, but is more common in patients with some type of organic heart disease. So PVCs, here are your characteristics all summed up. There's no apparent P wave. Most of the time, there isn't any atrial depolarization occurring, but sometimes when you get that retrograde depolarization, that P wave is going to be hidden. We'll get to some examples a little later where you can occasionally see the P wave. It's a premature complex, so if you're marching out your R to R intervals, you'll see that this QRS complex comes earlier than it's supposed to. And when you see it, it should stick out kind of like a sore thumb. These things are wide, they're big, and they just look plain bizarre. As you can see, it's not hard to identify that this beat looks a whole lot different than the ones that are around it. And that's how we can usually identify a PVC with pretty easily. Another thing I want to make sure we talk about is ST wave discordance. And I do have an entire slide on that here in a minute, but I'll go ahead and point that out for you here. So ST wave discordance just means that the ST segment and the T wave are going to point in the opposite direction of the QRS complex. So in this example, the PVC that we have is mainly positive. In other words, it's upright, and the majority of it is going up, right? So what we would expect to see, because it has ST wave discordance, is ST depression and a T wave inversion. And if you look closely here, the baseline is right here, and that ST segment is right here. So we do have some ST depression, and we have an inverted or upside down T wave, and you can see that's opposite of all the others. This is called ST wave discordance. Now, you may be asking yourself, why does it matter? Well, we haven't gotten into it yet, but very soon we're going to be talking about ischemia and infarction. And when we look at those things, we are looking at the ST segment and the T wave to identify those. Ischemia is oftentimes identified by ST depression, like you see here, and T wave inversion, like you see here. Infarction is going to be ST elevation, and we'll see how when the QRS complex is mainly negative, that's what we get with this T wave discordance. So it's important to recognize the situations in when this discordance is normal, so that you don't mistakenly call it something that it's not. So PVCs, there's no apparent P wave. We've already talked about this a few times. Occasionally there's a retrograde depolarization of the atria, but usually that's hidden and not something that we see, although on occasion you may be able to identify it. ST wave discordance, we just talked about that, but really the reason this is happening is because when you have a premature ventricular contraction, you're getting abnormal ventricular depolarization, right? Instead of it going through the His-Purkinje system, now you've got just the myocardium depolarizing, usually from one side of the heart all the way across to the other. So because things are abnormal when the depolarization happens, we also get the abnormal repolarization. This one's an opposite example of the previous EKG that we looked at. This one has a mainly negative deflection. So when the QRS complex is mainly negative, when we have ST wave discordance, what we would expect to see is some ST elevation and the upright T wave. And if you were to look right here at the baseline, you can see indeed where that ST segment's out here, we've got some ST elevation and the T wave is upright, and that is called discordance. Now let's talk about polymorphic versus monomorphic PVCs. Polymorphic just means that the PVCs have different shapes and different appearances when they occur. Now, obviously it has to be in the same lead. If you're not looking at the PVCs in the same lead, they're going to have different appearances simply because they're coming from different perspectives. If you look at the front of the horse and somebody else is looking at the back of the horse, well, obviously they've got different perspectives and things are going to look different. So we need to look in the same lead in order to determine whether or not the PVCs are polymorphic or monomorphic. So as you can see in the blue circle here, one of the PVCs has a downward deflection, the other one is an upright or positive deflection. And this has some clinical significance in the fact that usually patients with polymorphic PVCs have multiple ectopic foci that are firing, and that's because the myocardium in a whole has more irritability. These patients tend to be a bit more sick and deserve a bit closer inspection to make sure that things are okay. So polymorphic PVCs don't always mean that something really bad is going on with the patient, but it is something that we need to always kind of heighten our awareness and maybe do a little bit more investigation than when we have monomorphic PVCs like down here. Now, monomorphic PVCs just mean that when we're looking in the same lead, the PVCs will be identical to each other. So if we were to cut one out and paste it on top of the other one, they essentially look the same. And that's because they're coming from the same single ectopic focus in the ventricle that has some irritability to it. So that's polymorphic versus monomorphic. So what causes PVCs to occur? Again, you can be completely healthy and have a normal heart with no disease whatsoever, and simply the stress over your pharmacology exam or next EKG quiz will cause you to have some PVCs to occur. I think I was experiencing some tonight. I'd had quite a bit of caffeine, which usually doesn't bother me, but then I think I was getting a bit stressed out about this recording just not working out, and man, I'm telling you, I was feeling it pounding in my chest, and pretty sure I was having some PVCs. Feeling much better now that this is working out. Other things that can cause PVCs to occur would be hypertension, and long-standing hypertension leads to enlargement of the left ventricle, so left ventricular hypertrophy. Acute MI, if the patient's having an acute injury to the myocardium, it's becoming ischemic, and there's infarcted tissue around, then that irritable myocardium can release some premature ventricular complexes or contractions. Hypoxia is another thing that can lead to PVCs. So patients with COPD and sleep apnea, they would be more prone to experience a PVC, hypoxia. Wow. Okay, so hypoxia can be a cause of PVCs to occur. Now, medications can also be responsible for this. So beta agonists we often would give to patients to have COPD in order to help them breathe a little better. Well, this is going to speed up the heart rate, it's going to speed up the irritability, and we've already got a patient who's hypoxic, so that just further increases the risk for this ectopy. Decongestants and antihistamines, if you've ever taken Sudafed, you probably, if it bothers you like it bothers me, you'll feel that pounding in your chest, and you can have some ventricular ectopy because of that as well. So treatment for PVCs, well, usually none is required. They are typically benign and not causing a lot of symptoms or any symptoms at all. Now, if you're having a lot of PVCs, you may begin to feel some palpitations in your chest or feel like your heart's skipping a beat, as they say. In fact, this past week or two, I had a patient come into the emergency room who had complaints of palpitations, and we put her on the heart monitor and did a 12 lead, and she was having really frequent multifocal PVCs, which is just, again, a pretty unusual thing in an otherwise healthy 30-something-year-old lady. And upon further investigation, what she told me is that she had actually seen cardiologists in the past for the same symptoms and was placed on some antiarrhythmics as well as metoprolol, which is a beta blocker, for this treatment, to treat this in the past. But because she was feeling so good, she decided to stop the beta blockers about 2 weeks before she came in and started having some recurrence of symptoms. So if you're having frequent enough PVCs, you can be symptomatic from it, and then you may be taking some beta blockers to control that. So what I did is I put her back on the metoprolol and made sure she followed up with the cardiologist. Now, had this not been something that we knew that she had a problem with in the past, we'd be really concerned that she may have some cardiac ischemia or something going on. So if this is the first time you've seen a patient and they're having really frequent PVCs or multifocal PVCs, what I would recommend is that they get a cardiac workup to make sure there's not some ischemia going on from coronary occlusion or something that could be causing that. Other things to look at is the medications that they're taking. Are they on decongestants, antihistamines, beta agonists, and can we stop some of these? And if that's possible, because they're having symptoms, and we would want to go ahead and look at doing that as well. All right, ventricular tachycardia. This one we're going to start out with is monomorphic ventricular tachycardia. And just like monomorphic PVCs, when we have monomorphic ventricular tachycardia, all of the complexes are going to look identical to each other. And this is a serious and significant rhythm, something you need to be able to identify. Unfortunately, it's fairly easy to do that most of the time. And it's something we need to also know how to treat. These patients, when they go into ventricular tachycardia, or we call it often VTAC for short, will have significant hemodynamic compromise and cardiac arrest in most situations. Now, the good news here is, although as a healthy individual with no heart disease, you can have PVCs, it is highly unlikely that you will ever have ventricular tachycardia unless you've got some underlying cardiac disease. All right, now characteristics of ventricular tachycardia. Really, when you have VTAC, it's just PVC after PVC after PVC. So if you were to have 3 beats in a row that looked like that, then you would, by definition, have a run of ventricular tachycardia. Anything less than that, we just would call it PVC, or 2 in a row, we call that a couplet. 3 in a row, now you have a run of ventricular tachycardia. The rhythm will be regular. If we march out these R to R intervals, we'll see that it remains a regular rhythm. This is a good way for us to keep in mind our differential diagnosis. And then we also look at the rate. The rate for ventricular tachycardia is usually very fast. It's going to almost always be greater than 120 beats per minute, but typically it's at rates around 140 to 200 beats per minute. Now, because this is a ventricular rhythm, obviously the QRS complex is going to be wide, and that's because the rhythm's either originating most often in the right ventricle or left ventricle, and again, not going through that electrical conduction system and inefficiently traveling from one side of the heart to the other. Now, just like a premature ventricular contraction has no communication with the atria, ventricular tachycardia also has AV dissociation. So we'll go into that in a bit more detail here in just a minute. But here's a 12 lead of ventricular tachycardia. And as you can see, this doesn't look a whole lot like anything we've ever looked at before. It's wide, it's bizarre, it's very fast. And so if we were to march out these R to R intervals, you would see that they appear to be very regular. And if I was going to estimate, I'd say by the fact that these are 2 large blocks apart, that this is a rate around 150 beats per minute. So we have a very fast rhythm with a regular regularity, and we have a very wide QRS. So this is essentially our definition for ventricular tachycardia. Now, in a minute, I will throw one curveball at you, but hang on. For now, this was ventricular tachycardia. Let's talk a little bit about AV dissociation. Again, when we have this very fast ventricular arrhythmia, there's no communication between the atria and the ventricles. There's no conduction occurring through the AV node, either anterograde or retrograde. So the atria and the ventricles are essentially functioning as independent bodies doing their own thing. And because the atrial rate is acting at its normal rate, typically we're going to have a rate around 60 to 100 beats per minute if the SA node's in charge of the atria. The ventricles, on the other hand, because it's this ectopic focus that's firing, that rate's going to be much, much faster. And oftentimes, as you can see in this strip down here below, the atria depolarization is almost impossible to find. So the arrow here is showing you a P wave hiding inside of a preceding T wave, and that's why the amplitude is a bit higher than the one that's before it. And so that's a sign of some AV dissociation. The little gray circle here is showing you another P wave that's hiding in there between the ventricular complexes. Again, it escaped itself out, and it's showing that they are not communicating with each other, and a sign of AV dissociation. This is tough to see. I don't necessarily expect you to find these things, but if you can find them and you can identify them, it can kind of help you with your diagnosis of ventricular tachycardia. Now, there are a couple of signs of AV dissociation that I do expect you to be able to identify, because I think they're quite a bit easier. And that one of those is called a fusion beat. And if you look at the strip down below, we have this very fast, regular rhythm that's wide complex, and this is ventricular tachycardia, right? But what's this beat right here that's next to it? This one is called a fusion beat. And you may recognize these over here, and they look a whole lot like sinus beats. There's a P wave and a QRS complex, and so it looks a lot like a sinus beat. This thing in the middle that doesn't really look like VTAC and doesn't look like a sinus beat is a fusion beat, and it's a hybrid complex where an atrial depolarization meets up with a very late PVC or ventricular depolarization. And so you kind of get this mushing together of the two, and you get a beat that doesn't really look like either. And that's a sign of AV dissociation. The other one that we have is called a capture beat. And so down here at the bottom, we have a run of ventricular tachycardia followed by a beat that looks pretty dang normal, and that's because it is. What happened is the atria depolarized and happened to catch that AV node when it was no longer refractory, and the ventricles could be depolarized in a normal manner. So basically the atria captured the ventricles, and we get what's called a capture beat. And you can see that right after that we had another PVC, or potentially an ongoing run of ventricular tachycardia. Again, these are signs of AV dissociation. Now, I told you there was a curveball coming, and this is it. So SVT is another very fast, regular rhythm that we've discussed. And when all things are normal, it should have a narrow QRS complex. But imagine now if you had somebody with supraventricular tachycardia who had a problem with the His-Purkinje system, a bundle branch block. So depolarization down through the ventricles is delayed and becomes wide. So now you've got what we call SVT with an aberrant ventricular conduction or a wide ventricular depolarization. And that's going to look a heck of a lot like ventricular tachycardia. Now the good news is most of the time it's going to be ventricular tachycardia because this SVT with aberrant conduction is not super common. But we treat these completely differently, and so being able to know for sure is very helpful. I consider this really an advanced topic, and so I don't expect you to know too much about it, and therefore you've probably gone ahead and tuned me out for the next couple of minutes. But know these things here, know that things in your book exist, and then you can hunt them down and find them if you're ever in the situation or want to dig a little deeper. Now, I do want to explain what concordant QRS complexes are, because I think it's a good opportunity for us to review some information about the chest leads. So if you go back a little ways, you can remember that we talked about something called R-wave progression. Okay, so R-wave progression, and we start out in those right-sided chest leads, which would be V1. We would have a very small R wave and a deep S wave. That's because our depolarization is pointing essentially away from that right side. By the time we get to V3 or so, we would expect to see an R wave and S wave of near equal height, and that's pretty biphasic. And then by the time we get to V6, we would expect to see a very tall R wave followed by a very small S wave like that, and that's normal R wave progression. So when we say that these QRS complexes are concordant throughout all the chest leads, we're saying that when the patient's in ventricular tachycardia, all of the chest leads will look essentially the same. They'll either all be positive or they'll all be negative. Now here is the thing that you do need to tune back in to listen to, and this is the statement down here that's in bold and now circled in purple. When you're in doubt between which of the two that you're treating, you need to always treat it as ventricular tachycardia until you can prove otherwise. Otherwise, if we treat this patient as SVT, we can cause them to decompensate and end up into a worse rhythm. So if you don't know, treat it as ventricular tachycardia. So guess what? We're pretty much always going to treat it as ventricular tachycardia. So what can cause this? Again, people with healthy hearts and normal individuals will not typically go into ventricular tachycardia. These patients have to have some type of organic heart disease, or they're going to have to be having an MI that has caused them some damage to the myocardium. Now, medications can be to blame, and I'm sure if you've been in antiarrhythmics with Dr. Hames, you've talked about how antiarrhythmics are not only used to treat rhythm problems, but are also notorious for causing rhythm problems. So if the patient's on antiarrhythmics, we can potentially increase their risk for VTAC. Illegal medications or drugs, maybe we should call them, methamphetamines and cocaine, those can absolutely cause ventricular tachycardia to occur. as well as electrolyte abnormalities. So what symptoms do these patients have? Well, they're going to almost always have significant symptoms. On a rare occasion, I have seen patients come in ventricular tachycardia who are sitting up and talking and saying, yeah, my heart feels like it's going a little fast, but that is rare and unusual. These patients are typically diaphoretic, complaining at the very least of palpitations, but most often chest pain and feeling short of breath. And in usually a matter of minutes, these patients are suffering from hemodynamic collapse. Well, why would that be? If we've got the ventricles are pumping and they're pumping quickly, you would think our cardiac output would be good, right? No, you would be wrong if you said that. And so let's review why that would be. Now we have what's called atrial kick. If you remember back to early on in the anatomy and physiology, and even as we discussed atrial fibrillation, we brought up that atrial kick, or that contraction of the atria, will supply somewhere in the neighborhood of 10 to 30% of the blood volume that enters into the ventricles. Now, when we lose that atrial kick, we're losing that additional blood volume. And so now we're completely reliant upon passive filling of the ventricles. Well, if the ventricular rate is so fast and the ventricles are pumping so quickly, they're really not allowing any time for passive filling to occur. So the amount of blood volume that enters into the ventricles is decreased, which ends up causing a decrease in cardiac output, which causes a decrease in the blood pressure, which also causes your patient to fall out. So how do we go about treating ventricular tachycardia? Well, on the rare occasion that the patients are stable, we could consider things like beta blockers, metoprolol and carvedilol. Medications are typically going to be given by an IV route, and this is because we want to address this very quickly. This patient is prone to decompensate. If they haven't already, they're going to be decompensating in a relatively short amount of time. So giving things IV is important. Now, medications that we would look at are antiarrhythmics such as amiodarone, procainamide, and lidocaine. If the patient's unstable but still has a pulse, we do what's called a synchronized cardioversion. Okay, synchronized cardioversion is when they have a pulse. A synchronized means that we want to provide the electricity at the time of the R wave. Now, I think it's somewhere in the book where we talk about an R on T phenomenon. So if you were to cause a PVC or this outside electricity to occur on the T wave, you have the potential of setting off the rhythm of like ventricular fibrillation, which we'll get to in a minute. And so we need to make sure that we're synchronizing our electricity right on top of that QRS complex. And in fact, one of the settings on the machine will have a little dot that lands above the QRS complex to help you know that it is synchronized. And it's always something that you want to check for before you cardiovert the patient. Sorry, I keep trying to say defibrillation. Defibrillation is essentially the same thing, except in this situation the patient does not have a pulse. We're not worried about synchronization at all, and we just defibrillate. We provide the electrical impulse. Defibrillation is usually going to have more energy than the cardioversion. That means we have a higher number of joules that we use when we defibrillate a patient versus when we do the electrical cardioversion.